Hello, I'm pleased to provide the next in our series of updates on COVID-19 therapeutics. This is the May 2022 update. These are my disclosures. Today, I'm going to cover 4 topics. A new important negative study on the use of ivermectin in outpatients with COVID-19. A positive study on the use of COVID-19 convalescent plasma, or CCP, for outpatients. An update on a meta-analysis of remdesivir in different populations of hospitalized patients with COVID-19, and a study on the potential benefits and risks of anti-platelet therapy, one of the REMAP-CAP studies. So let's start by talking about ivermectin. As you know, ivermectin, which is principally used as an anti-helminthic, an anti-parasitic drug, has been very controversial, with previous studies showing the drug to be ineffective in patients who are hospitalized for COVID-19. But there hadn't, up until now, been studies in outpatients, and its use has persisted in some parts of the world. The Together trial tested early use of ivermectin in non-hospitalized patients with COVID-19. This was a randomized, double-blind, placebo-controlled trial conducted in Brazil, and participants received ivermectin at a dose of 400 micrograms per kilogram or placebo by mouth for 3 days. Primary composite outcome was hospitalization or emergency department visits for COVID-19 within 28 days of entry into the study. This was another one of these platform trials, so 3,500 participants were randomized, but only 680 or so to ivermectin and another 680 to placebo. The remaining 2,100 participants were randomized to other therapies. To be eligible for this study, participants had to be age 50 or older and have at least one risk factor for progression to severe COVID-19. Importantly, participants who were vaccinated were allowed into the trial, but the paper didn't report the proportion of participants who had received a vaccine. Eligible participants had to have been symptomatic for COVID-19 for up to 7 days prior to study entry, and they had confirmation of SARS-CoV-2 infection by a rapid antigen test prior to randomization. This slide shows the primary outcome. Here we're looking at the relative risk of progression to hospitalization or an emergency department visit. And these are Bayesian statistics. So we're looking at the Bayesian credible interval, which is conceptually similar to a confidence interval. We see the primary outcome in the intention to treat population. There's a modest 10% reduction in risk, but that did not achieve statistical significance. And in the secondary analyses using either the modified ITT population or the per protocol population, again, the same very modest reduction in risk and no statistical significance. We look in different subgroups by age, body mass index, presence or absence of cardiovascular or pulmonary disease, by sex, smoking status. We see, and time since onset of symptoms, we see that across the board, there is no evidence of any benefit. So in conclusion, there's no significant or clinically meaningful reduction in risk of disease progression in outpatients receiving ivermectin. There remains no credible evidence for the use of ivermectin in the treatment of COVID-19 in any setting. Let's turn now to convalescent plasma. Studies of convalescent plasma to date have provided mixed results, with most randomized clinical trials in hospitalized patients showing no benefit, but some suggestions that treatment very early might have some benefit in certain subgroups. There have been limited studies of CCP in outpatients to date, however, and the CSSC 004 study tested the use of CCP for prevention of disease progression in non-hospitalized patients. Here, eligible participants included adults with symptomatic COVID-19 who were within 8 days of symptom onset. They had to be age 18 or older, and there was no requirement for coexisting medical conditions. So this is really a very different group of people than what we've seen, for example, in the monoclonal antibody studies, who've had to be older patients or people with coexisting medical conditions. This is a much more general population. In addition, vaccinated participants were allowed and constituted just under 20% of the study population. They were either partially or fully vaccinated. Most of these participants who had some vaccine were, in fact, fully vaccinated. This was, again, a randomized, double-blind controlled trial, and the participants received either high titer antibody or plasma, that is, that had titers of greater than 1 to 320 of the anti-spike protein antibody, or a control plasma, antibody negative plasma, which is very important. This is a well-designed study. Rather than using just a saline control or standard of care control, they actually received antibody negative plasma. The primary outcome was COVID-19 related hospitalization within 28 days. There were more than 1,200 participants randomized equally to placebo or CCP at 23 sites throughout the United States. Now, important as we think about the timing of this study, the plasma units were collected between April of 2020 and April of 2021. The participants were enrolled from June of 2020 through October of 2021. So whereas in the first part of this study, we're really looking at the original variant of COVID-19, towards the end of the study, we're beginning to get into the period where beta and then delta were circulating, although most of the plasma units were collected at a time before alpha had emerged. Nevertheless, if we look at the cumulative incidence of COVID-19 hospitalization, we see that there was a significant reduction in the risk of hospitalization in those who received CCP compared to the control. Here you see the Kaplan-Meier plots with these colored bands representing the 95% confidence interval in the unadjusted and adjusted analyses. Risks, of course, overall were low, about 6% for those in the control and 2.5% those in the convalescent plasma, but a significant reduction. If we look at the actual numbers, we see that there were 37 participants in the control group and 17 in the convalescent plasma group who progressed to the primary outcome, and that was a highly statistically significant difference. There were similar differences in the expected time free of hospitalization, only a one-day difference, but it was significant, and the probability of remaining hospital free was about a 4% difference, and again, highly statistically significant. Looking at subgroups, there's some interesting differences that emerge. We see that overall, CCP was effective regardless of gender, regardless of body habitus, regardless of age. If we look by vaccinated status, among the fully vaccinated, there were no progressions, and so you couldn't, in either group, so you couldn't see any advantage of CCP. But the big difference was in the duration of symptoms, where there's a much more obvious benefit for those who received CCP within 5 days of symptom onset, and really no difference or benefit for those who waited for 6 days or more before they were treated. Also a suggestion that those who had already higher C-reactive protein levels, so more inflammation already being triggered, were less likely to benefit than those who entered with normal CRPs. So in conclusion, early administration of high titer CCP can prevent progression to hospitalization in symptomatic outpatients, whether they are older or younger, and whether or not they have coexisting medical conditions. The relative risk reduction was about 50%, and the number needed to treat was around 30. This was most effective when given within 5 days of symptom onset, very similar to what we see with the monoclonal antibodies and other oral therapies for outpatients, and there was no benefit in vaccinated patients. Importantly, no data are presented on the matching of the units of plasma to the prevalent SARS-CoV-2 variant. And as a reminder, most plasma was collected in 2020, and beta and delta emerged in 2021 as the trial progressed. Well, let's take a quick look now at an updated meta-analysis of the efficacy of remdesivir in hospitalized patients. This is an analysis done by Kaka and colleagues. It was initially published last year in Annals of Internal Medicine, and now that several additional trials and other cohort studies have been published, they have updated their meta-analysis. Looking first at mortality for remdesivir given for 10 days versus control, we see that there is a numerically modest reduction, about 6% reduction, but that fails to achieve statistical significance. And this updated analysis is consistent with what we've seen previously, and of course is heavily weighted by the negative results of the Solidarity study. If we look at non-mortality outcomes in terms of the proportion who had clinical improvement, comparing those who received remdesivir to those who received either standard of care or a placebo control, here we do find a benefit, again modest, about a 10% increase in the proportion who have clinical improvement that is statistically significant. So modest but clear benefit of remdesivir for this endpoint. Looking at ventilatory support or ECMO, here the results frankly are a little bit confusing. Those who were still receiving ventilation or ECMO at follow-up was significantly reduced among the remdesivir recipients, about a 25% reduction, which is clearly statistically significant overall. But in terms of progression to ventilation or need for ECMO, there was no difference, although only 2 studies were able to examine that endpoint. Now, previously, we've said that remdesivir had less benefit in people who were already on a ventilator or receiving ECMO, and yet here the analysis seems to show that perhaps there was a benefit. So this is going to require some additional thought to really tease out. Then lastly, looking at serious adverse events, there was a suggestion of lower incidence of serious adverse events among those receiving remdesivir compared to control, but that did not achieve statistical significance. So in conclusion, in hospitalized patients with severe COVID-19, remdesivir does not improve survival, but it does increase the proportion of patients who recover. It may speed the time to improvement, and there was a small, albeit not statistically significant, reduction in serious adverse events. Lastly, let's turn to the REMAP-CAP trial of anti-platelet therapy. As you know, REMAP-CAP is an adaptive platform trial. We've looked at many different domains of this trial over the last year and a half or 2 years as the data have become available. And this particular domain that we'll focus on today included a little more than 1,800 participants who were randomized within the anti-platelet trial domain, in which participants were randomized to receive either aspirin, the P2Y12 inhibitor, one of them, either clopidogrel, prasugrel, or ticagrelor, I should say, or control. Many were, or most were receiving concurrent anticoagulation administered per local standard of care. So that would have been either prophylactic or standard dose heparin or other anticoagulant. Eligible participants were patients who were hospitalized with COVID-19, and the primary outcome was respiratory or cardiovascular organ support free days through day 21. This slide shows the primary outcome, and I'll take a little bit of time to take you through the representation of the data here, because how the data are displayed when we're talking about organ support free days, it does not come across intuitively, because first of all, the result always adds up to 100%, but what we're really looking at is day by day, how many or what proportion of the participants did not require organ support, and how many days did they spend without organ support. So obviously the people who died in the study, they are taken out early. But there are participants who spent no days without requiring organ support, so ventilatory support, ECMO, and the like, and they constituted roughly 30%. And then there was another 10% or maybe 20% who spent only 1 or 2 days free of organ support. If we look all the way over here to the right side, you see that, again, a very small percentage, 5%, spent the entire trial, 21-day period, without requiring any support. And then another 5% were free of support for 20 days and so on. A different and perhaps more intuitive way of grasping this is looking at these the horizontal display where you go from red to blue, with blue being the better outcome, and you can see what proportion of participants spent 0 or up to 21 days free of organ support. And what you can see here is that there's really not a huge difference in this distribution among those who received any kind of antiplatelet therapy, either all of them pooled together, focusing on aspirin alone, or the P2Y12 inhibitors alone, compared to those with who received no antiplatelet therapy. On the other hand, if we look at 90-day survival, there is actually a statistically significant survival benefit for those who received either aspirin or the P2Y12 inhibitor, or when we pool all of the antiplatelet therapy. And that was about a 22% increase in the likelihood of survival. Again, this study was analyzed by Bayesian statistics, and so the way to think about this is that there was a near certainty, 99.7% posterior probability, that receiving a platelet inhibitor would provide some survival advantage. So, conclusion, among patients critically ill with COVID-19, antiplatelet therapy did not reduce organ support-free days, which was the primary endpoint, but it did, however, result in a modest improvement in survival. This survival benefit, however, was counterbalanced by a small but definite increase in the risk of major bleeding, which again balanced out the improvement in survival. And so that overall, the conclusion in this study, and from the really very insightful editorial that accompanied the primary paper, the editorial written by Connors and Ridker, suggested that there's no benefit to adding antiplatelet therapy to heparin anticoagulation in patients hospitalized with COVID-19. So thank you very much for your attention, and I look forward to the discussion.